Well, welcome everybody. We have a very good number of attendees this evening. Welcome to our webinar, Arthritis, COVID-19 and You Consumer Information webinar. My name is Jonathan Smithers. I'm the Chief Executive Officer of Arthritis Australia. This webinar is hosted jointly by Arthritis Australia and the Australian Rheumatology Association. There are a very large number of people on the call. Your voices will be muted, obviously because it would be too much to have everybody speaking. I would like to start off by acknowledging the country. I'm dialing in from Sydney, from Gadigal land this evening, and I'd like to pay my respects to elders past, present and emerging, and from all the lands on which we're meeting tonight, and pay my respects particularly to any Aboriginal or Torres Strait Islander people who are participating this evening. This webinar is designed to give you information about vaccination and to give you the opportunity to ask questions as well. But we want to highlight the importance also of speaking to your GP or your rheumatologist about your individual circumstances. That can't be overemphasized in doing so. And we're very, very lucky this evening to be joined by two distinguished panelists I'd like to introduce. Firstly, Associate Professor Philip Robinson, rheumatologist, and Associate Professor Jane Munro, who's a paediatric rheumatologist. Both are going to speak to us all this evening, and then we'll go into a question and answer session after that. You should be able to see the Q&A tab, the question and answer tab in the middle of the bottom of your screen. If you have questions, please type them in there. And you won't be able to see other people's questions as they come up, but we'll moderate those and hopefully we'll get through a good number as we go through this evening and try and answer as many as we possibly can for you. And both Philip and Jane have agreed to help us with all of those. And we've had one or two questions in advance as well. So that's what that function is there for. And this is designed to be interactive. So please do keep those questions coming in and we'll deal with as many as we possibly can. I should say that the session is being recorded, so it will be then made available on the Arthritis Australia website for those that haven't been able to dial in this evening, or if you want to re-listen to it again, that's where you'll find it. We also are planning to finish promptly at 7:30 p.m. So that you know there will be a stop at that point. So without further ado, we've got a very large number of people who've joined us. May I hand over to Philip Robinson, who's kindly agreed to speak and has some slides to show us who's going to share. Philip, thank you.
Thank you for the invitation to be involved. Can everyone see my slides? No, no yes. One?
Yep, I think so.
Great, okay. Those are my personal disclosures, not particularly relevant. So vaccine types. I'm going to quickly run through the vaccine types that are available for COVID-19. So they're the AstraZeneca vaccine, which is the viral vector vaccine, then the 2 mRNA vaccines that you will be familiar with. And then most recently, the new kid on the block is the Novavax, which is a protein subunit vaccine available. All of these ones have 2 injections and we're not really considered protected until you've had both of them for at least 7 to 14 days. So at this current point in time, this is how many vaccines is recommended. You have your 2 primary and then your booster vaccine. Now, for those classed as immunosuppressed, and I'll certainly touch on this later, there's a standard regimen with a 3rd primary and a booster. So that is 4 vaccines. Now, there is some confusion. So I've made some pretty graphs and hopefully that makes it, oh, okay, sorry, before I show the pretty pictures. So this is what ATAGI has defined as those who can get a, the government vaccine guideline group. Those who can get a 3rd primary vaccination. So those on greater than 20 milligrams of prednisone for 14 days or on pulse corticosteroid therapy. So that's intravenous normally. Multiple immunosuppressants when in the judgment of the doctor, the cumulative effect is severely immunosuppressant. And then the more traditional oral tablets we have and the doses, and then rituximab and JAK inhibitors, but they specifically say these ones are not. So what are the recommended booster vaccines? So these are the recommended booster vaccines. You can get AstraZeneca if you can't have a Pfizer for medical reason, or you've had two previously. When to get it, I'll show you in my weird pictures, but it's 3 months or longer from your second dose, or should I say your most recent dose, if you've had a third. And the guidelines from ATAGI is that if you test positive for COVID-19, you can have your next dose of vaccine once you're fully recovered, or you can choose to defer that 4 months after infection. So I've got 4 wee graphs here to show how it would work. So if you have a standard AstraZeneca series, you'll have your 2 primary vaccinations followed by your booster greater than 3 months since your last dose. If you're eligible for and you choose to have a third primary, that's what you'll have 8 weeks after your second primary, and then you can have your booster. And it really follows the same, except the intervals are slightly different for the different vaccinations. But essentially, your third primary should be 8 weeks after your second primary, and your booster should be greater than 3 months after your last dose. Novavax the same. And then Moderna. Now, Moderna, I should say, with Pfizer, the doses remain the same. With Moderna, your booster dose is half of your full dose Moderna. So, and this is where there's been some confusion in that some people who've had a third instead get a booster. And so it's important to tell your vaccine provider, if you're getting a third primary, that this is your third primary and you need a full dose Moderna, not a booster dose. And that's only relevant for Moderna. Now, some medications impact on the ability for you to respond appropriately to vaccinations. Now, this is just a study. I'm not going to run through it, but essentially you get a boost in the response to vaccine if you withhold your medication. So the next question becomes, withholding medications, do I withhold my medications? And if I do withhold my medications, how long do I do that for? And this is not a straightforward question, and it's got lots of factors to consider, but it's something you need to talk to your GP or your rheumatologist about. The benefits of vaccination are clear, with reduced disease severity, reduced hospitalization and death. The potential downsides are around local reactions, and there are specific side effects associated with these other medications that are low risk compared to the benefits that we get. Now, the myocarditis associated with mRNA vaccines is very small, and it's important to remember when you focus or you think about this, that in fact, the risk of getting myocarditis from the disease itself is actually greater than the risk of getting it from the vaccine. So that's, you need to always, when you're thinking about downsides, think about what you're doing it for and think about the upsides. And you can see that the frequency is 1 to 3 per million doses of vaccine. Now, one of the other questions that people ask is, will this flare my disease? Will getting a vaccination flare my autoimmune disease? This is a range of different measures of disease activity. And I'll run you through the most left-hand one. So that's the rheumatoid arthritis disease activity. And you can see here in this group, around 20% improved after their vaccine, around 60% had no change, and around 20% worsened their disease activity. And you can see that across all of the different diseases. We certainly do see in a low proportion of patients some getting flares of disease, but they're generally able to be well addressed by adjusting therapy in some cases. So what do you do if you test positive for COVID-19? You need to talk to your GP and rheumatologist. You need to ask them the question about should you be treated with or eligible for specific treatments for COVID? And if you're unwell, you just need to do the normal thing that you would do, which is contact your doctor or hospital or call an ambulance. So what are the take-home points? The risks associated with vaccines outweigh their benefit. A third primary vaccination is a good idea if you're eligible, and that's because some medications mean that the vaccines don't work as well. A booster shot is also a good idea, and that's because the efficacy of vaccines wane with time. Talk to your doctor about any changes in medication that might be required, and disease flares are uncommon, but they are seen with vaccination. Thank you.
Philip, thank you very much. I hope the attendees have found that helpful run through. Obviously, it's quite complicated, and some people have gone through that over the past few months. Obviously, the whole situation is emerging, and I see there's one question already about if you've had a half dose, should you have more? We can perhaps come back to that. So thank you very much. That's very informative. Jane, could I pass over to you to speak now, please?
Yeah, thank you so much. Thanks so much for having me here tonight. Philip's gone through a lot of the basics around vaccinations, and for children, obviously they came on board a lot later, the vaccination schedule from September last year in the 12 to 18-year-olds, and they had an incredible rate of vaccinations. And then from January this year, we've had 5 to 11, which has had a slower uptake. For immunosuppressed young people, there's a schedule there, and there is from December, there was an announcement by TAGI, who oversees the rules around vaccination, and there was a recommendation for the 3rd primary dose for very similar criteria that Philip had around immunosuppressed young people. And the important things there is that for most young people who are on doses for arthritis, juvenile arthritis, for the biologics, certainly for the higher doses of methotrexate, and for things like leflunomide, which is a smaller percentage of our young people, certainly for young people with dermatomyositis or lupus, a number of them would be on the level of immune suppressants that would need a 3rd dose. But the most important thing is that having spoken to the teams around the country over the past few months, the nursing staff and our rheumatologists are very approachable about this. They've all got immunisation services at the paediatric hospitals that support this, and there's information on most of the websites around it as well. So if you've got any doubts at all, particularly for children, I would speak to your rheumatology team. The nurses at the service is particularly expert about this, and they can inform you about which dose your child which vaccine your child is due for if you've got any confusion. The tricky thing I think about COVID is every time you turn around, there's a new rule change, be it from, quarantining or what you've got to do, rat testing in schools or not, depending which state you're in. And I think that makes it really confusing for parents, and they're looking after their own health as well as their children's. And so what I would do is, for example, with the vaccination, it does change sometimes. And so in the timing, so for some of your children who are not on immune suppressants, their dose schedule is 8 weeks between the 1st and 2nd dose. But for your kids who are immunosuppressed, it can be 3 weeks. Not everyone remembers that. So it's just worth asking the question, if your child is on any medication or immunosuppressed, say, does this mean they have to have a schedule change? Do they have to have different vaccination timing or a different vaccination? And again, the rheumatology team can advise that for you. The things that we find now most commonly that people are asked, because we were asked a lot of questions last year around safety and around access to the COVID vaccine. People were desperately wanting to have it for their kids who are immunosuppressed. Now we've got access, and we've got access to booster. We've got good safety data, and it is available everywhere for children to be able to access it, which is great. It's really about just making sure that people know, Philip talked briefly about the medication and whether you should stay on your medication. Always worth asking that question. But in general, for most of the medications, we generally would keep children on their medication throughout while they're on getting the COVID vaccination, but always worth. It's an individual case-by-case discussion with your treating doctor. And the other couple of things that have probably come up regularly recently would be around, if my child has had COVID, do I need to get the COVID vaccination? That's probably the number one thing. And generally the rule is once your child has recovered and feels well and 4 weeks has passed, that is when you would get them their next dose of the COVID vaccine, or the first dose, depending what they're due for. So depending on their age and their clinical situation. But again, always just go back to your team or the vaccine, the vaccine service at your child's hospital, for example, or the state hospital. They've always got so much information, and they prioritise young people who are immunosuppressed and will give you that information. I think that was probably all I wanted to say. I've got lots of other little bits and pieces, but they're the kind of key things that we found. I asked a number of the team members, medical and nursing, and our immunisation service in the lead up to this to get the kind of hot topics that they're getting at the moment from our families and key issues.
Jane, thank you very much. Again, very helpful updated information. As you say, this has been a evolving situation now for a very long time. The rules keep on changing, different in states, and the advice sometimes on the length of time between vaccinations has changed and for different people. So go back to what I said right at the beginning, really important for individuals to speak to the rheumatologist or GP about their circumstances. The rheumatologists and GPs should be well informed about this and be able to speak about individual circumstances. Now, we've got quite a few questions coming in already. I'd like to dive into the Q&A session now so we can try and deal with those as many as we can. Now, I don't propose to give the names of the people who have asked the questions, so they'll remain anonymous, which I think is then fair to everybody. But Philip, could I just start off with one for you? A question that's come in: should you get a 4th vaccine if you are taking an immunosuppressant biologic?
Well, a 4th vaccine, by that, does the person mean a booster? So if the patient's had 3 primary vaccinations, yes, they should be boosted. Everyone should be boosted. That's what the recommendations are. Now, should you have a 3rd, one of those extras on a biologic? It depends which biologic you're on. ATAGI has put out the recommendations, which would suggest that those on TNF inhibitors and IL-6 inhibitors and those that inhibit the IL-17 and 23 and 12/23 don't need boosters. But it's complicated because lots of patients are on combination therapy. So this is something that you should talk to your doctor about. It's complicated and it is impacted by lots of things. So talk to your doctor.
So no one rule for everybody.
Correct. And then there are other reasons why you might not essentially follow the rules as well. So it's a very individual case.
Other factors that might be comorbidities potentially.
Yeah, there are lots of reasons, including disease factors and things. So yeah.
There's just a follow-up, which is an aside from that, from an individual consumer. I have the biologic Cimzia. Does that mean I'm part of the immunosuppressed mentioned earlier? The slide went off the screen a bit too quickly to read.
Yeah, so if you were just on Cimzia, the guidelines would say that you are not potentially eligible for a 3rd vaccine. But that's, as I say, commonly patients are on combination therapy or they have other issues. And so this is something you need to talk to your doctor about.
Okay. And then another one, perhaps just to follow up, I had the 3rd dose Moderna at the pharmacy. I'm unsure whether I had a full dose or a half dose. What should I do?
Well, I would suggest that you either look on, My Health Record or I'll go and talk to your pharmacy. I would anticipate that they would have kept a record of what sort of dose that you would get. I would very much hope that they'd kept that record. And so if you didn't get the full dose and you should have got the full dose, then that can be rectified and you can be given another half dose.
Okay. And then sort of following on to a number of questions around this, does it matter if there are different types of vaccines? AZ, Pfizer, and Moderna. Does that make a difference? Is there a recommendation?
So the recommendations from ATAGI is that all things being equal, you should get an mRNA booster. But there are lots of reasons why that might not be the case, like, you know, if you've had a reaction or other things like that. And so it's something that you should talk to your doctor about. They're all effective vaccines that have gone through the regulation process. ATAGI have got lots of people have spent a lot of time thinking about how best people be vaccinated. And so it's best to follow the ATAGI advice if it works for you and there's not a situation why you should change that.
Thank you. There's a number of questions are coming in and follow up to these. How do you identify if you've received a primary versus a booster? And I guess that's in the definition of what's primary, if it's a third dose of primary and a booster. How do you identify that?
I mean, there are people who would have got a third vaccination and they thought they were a booster. In fact, they're potentially eligible for a fourth if they're in that situation. But you need to keep those, you need to keep in mind the differences but if you have waited too long and you have got and you have been vaccinated as per the normal schedule, essentially, and not got your third primary vaccination, then that's something you should talk to your doctor about, because maybe you're in a low risk group. Maybe there's not actually any point if you've waited all that time period and now you've just got a booster. Maybe there's not much point then a few weeks later getting it. So if you've sort of got vaccinated outside of the schedule, been vaccinated as part of the normal schedule and you don't know what to do, you should just talk to your doctor. Because that may be the situation where your doctor says, look, it's a great idea, I think we should get you a fourth one. Or they might say, look, in your situation, no.
That leads on very well. Sorry, forgive me, Jane. I'm conscious all these questions are coming in for Philip. I had my booster 8 weeks ago, numerically the fourth shot, and read that it only protects up to about 12 weeks. Is my immunity running low? Is there news about additional shots following that?
You know, there's been discussions in the media, and if you look across to the US, there's discussions about fourth normal scheduled doses, or, you know, second boosters that have been discussed. But at this current point in time, that's not recommended by the government. But there are clearly lots of people thinking about this issue. The reason that we're getting boosters is because our vaccine immunity wanes with time. And the reason that patients with rheumatic diseases and autoimmune diseases are getting extra boosters is because they sometimes don't get the best response they can. So I would just keep an eye on, and, you know, keep an eye on this Arthritis Australia website, the Australian Rheumatology Association website, the Department of Health. You can go and actually look at all the advice that the doctors are using yourself if you want, and read it. You don't have to rely on your GP. If you don't want to talk to them, you can go and read that yourself. There's all this information is publicly available.
I guess it's also confusing if you're looking at news from overseas. Different countries are giving different advice sometimes about those, and obviously the vaccination programs in different countries have run at different speeds as well. So that can lead to some confusion. But as you say, in Australia, I'm right in saying then a fifth dose is not yet available.
Yeah, that's correct.
Right. Okay. It's an interesting, slightly different question here. Is how do I tell the difference between an adverse effect of the vaccine and an arthritis flare? They're very similar. In both cases, I experienced shoulder pain.
Well, I think the short answer is you can't. And you just have to manage the situation. So if it's becoming a problem, then you need to go and talk to your doctor about it, or you know, discuss with whoever you deal with, your vaccine provider. They might be able to provide some guidance as to try and help you delineate whether it's a vaccine adverse event or a flare of your arthritis. But, you know, just go and talk to your doctor. It's the important thing.
Now, here's quite a specific question. I'm a 67-year-old female taking methotrexate and Enbrel injections weekly, but 2 AstraZeneca vaccines and a Pfizer booster. Do I need any more? And if so, what?
Yeah, so this is a specific situation that you're probably best to talk to your doctor about. I don't know the doses of methotrexate that this person who's asked the question is on, and those, for example, ATAGI has restrictions around doses. So if you're unsure, go and ask the question. And even if you think you know the answer and you want reassurance, that's what your doctor's there for.
And they should be able to answer that fairly easy because they'll know the doses because they
absolutely, yeah. And lots of rheumatologists are taking lots of calls about these questions, and all of my personal patients have been asking these questions, and I've been getting back to them about it. This is just part of what we do at the moment as rheumatologists and GPs, is deal with these issues. So I don't think you should be reluctant about asking them, because that this is your health.
There's another question here, and Jane, perhaps you want to take this. It's not specifically for pediatric rheumatology, but is there a blood test to detect your level of immunity? How will you know what your level of immunity is? Would you like to...
We don't test for that, but Philip might answer something different in adults.
Yeah, so in adults, we don't actually know what the correlation between the level is in your blood and what protection you have. So the only real use of blood tests is working out whether you've had any reaction. So there are some medications that work when you treat COVID that work in those that are what we term seronegative. Now, that's not talking about rheumatoid factor, that's talking about antibodies to the virus. So this is just about the virus here. For example, some patients on specific medications, you might want to go and do a blood test to see whether they've responded or not. And at the moment, there are discussions going on about prophylactic treatments, and often those will involve testing the response. But essentially, we get a yes/no answer. Have you had any response to the vaccine? Yes or no.
Okay, thank you. There's a much more general or generic question. Once we've had 4 doses, or presumably 3, if you can't get the 4, how worried should we be about COVID? Are we safe? Do we still need to be careful?
Is that for me?
Please, Phil. Yes. Yeah.
So that's why we give vaccines. Vaccines are there for protection and for improving your response to the vaccine. They're not perfect, and there are lots of other factors that go into whether you will do well or not, or whether you will sail through, or whether you'll become unwell. And that includes who you are as a person, your genetics. None of these things we can control, our age and our gender. So, we can't avoid getting old. And so these things are just sort of part of who we are. And then there are the other diseases that we have, including, high blood pressure and diabetes and all of these other things. They influence how well you're going to do. So the best thing that any one individual can do to keep themselves safe is to get well vaccinated and follow public health advice. So in situations where you can't socially distance, you wear a mask and you use good hand hygiene. And you're really sensible about these things. And there are people that choose to do different things. So there are people that choose to not, for example, go to activities because they're concerned about their personal risk. And that's a choice that we all have to make depending on the risk that we have. And if you're unsure about the sort of risks that you have, then that's another thing you can talk to your doctor about. They might be able to provide some reassurance, or your rheumatologist, and say, look, in essence, I think that you're going to be fine to go about your life as normal, etc. And these are all complicated things that are influenced by lots of factors.
Can I add to that? I really strongly, there's 2 messages there. Firstly, strongly believe in vaccination. I strongly believed in it throughout the whole pandemic and pre-pandemic. As a paediatrician, we're exceptionally strong on vaccination. The job I've had, in addition to the paediatric rheumatologist for 6 months, is in Brett Sutton's COVID team in the Department of Health in Victoria, and so have sat very much as a senior medical advisor, seeing day in, day out the very close stats about the importance or the impact, because it's often reported as unvaccinated and vaccinated individuals, and not just here but around the world. We get reports every day, and there's absolutely no doubt that in terms of preventing severe disease and death, vaccination is incredibly important. So not just to you, but to your family members who may not have rheumatic diseases and immunisation and immune suppressants. So it's just, it doesn't mean you won't get it, but it should, not always, but should make a massive difference in terms of reducing your risk of severe outcomes. And the second point that Philip made is, when we talk things, we talk across the board. We're giving you the global information that we have. That's what we have to do. When we're in a consultation room, I'm sitting there talking to my patient Meg and her mum and dad. I'm looking at her file. I know Meg really well. I've looked after her for years. I understand her doses. I know how her disease flares. Was her disease really easy to get under control? Wasn't it? How, and we work it out together, and we make a team decision with Meg at the heart of that. And you as a patient, understanding your risk of COVID now 2 years, this third year of a pandemic, and Omicron got off the plane and smacked us like a dead fish in the face on December, and another variant could come, and hopefully it won't, and hopefully it won't be bad, but understanding how to protect yourself and understanding, is your immune suppression risk really mild? Are you on a teensy little tickle of a dose and it's not a big deal, but because you've got this label of immune suppressant, you are freaking yourself out and you're wrapping yourself in bubble wrap, and your third year of pandemic? Or are you on a massively high, really risk dose, and your rheumatologist is worried? And there is a big, scale there. And I think becoming really literate, understanding that and understanding your risk or because then you can make decisions. You can say, well, I actually understand I could go out now, but I'm going to sit in an outdoor cafe. Or third year of a pandemic, I'm caring for someone and I need to be able to go into shops, but I'm just going to wear, this is the mask I'm going to wear. It might be an N95. Or actually, my rheumatologist is not that worried. And they say, my risk is only a teensy bit above. And now I've had a booster. I'm actually only just a titch above everyone else. So I can make decisions based on the kind of advice they're giving everyone else. And I'm pretty good just wearing this mask or an N95. So you can make those decisions, but you have to do that little bit of extra effort in learning about your personal risk. Because when anyone gives out that public health advice, that's for the whole population. And even when we give immunosuppressed vaccine advice, that's for all immunosuppressed people. You need to have that one-on-one discussion with your rheumatologist or your rheumatology nurse.
Jane, can I just pick on something that you were talking, obviously very, very strong on vaccinations and how that should protect you against severe disease. How about transmission, and particularly if people have children who may be picking it up at school, and what about the transmission rates for people who've had it, who may be asymptomatic?
We know vaccine it reduces it, but it doesn't completely prevent it. Yeah.
But it's a good thing just for that.
It is good. It is good for that, and that is absolutely helpful. And we know where there's high vaccination rates, there's reduced transmission. But again, you can't just rely on that. No. So this is where it's this helpful. Layered. Yeah. It's helpful, and it's where it's this layered approach. Yeah.
And can I pick on something you mentioned, Phil, about hand hygiene? I've read a couple of times recently in the newspapers, economists are saying, everyone should get vaccinated, but people are still washing their hands, and we know that's not how it's transmitted. Is that still important? Is that what's the advice? I mean, obviously, general hygiene, it might be a good idea, but in terms of COVID and the transmission of COVID,
should people still be washing hands?
Yeah.
People should be doing all the standard public health advice, because that's how it's transmitted. And so, we're still discouraging people from hugs and handshakes and all that sort of thing, because that's how it's transmitted. It is still out there, and I'm not going to get into variants, but, there are potentially new variants out there right now that are brewing or currently infecting people, that we could have a Delta or we can have an Omicron, we could have the whole thing all over again. So this is reducing the transmission means that fewer people get unwell, and there's less in the community.
Yeah. Okay. Thank you. Can I go to a quite specific question we've had? Does receiving the monoclonal antibodies mean you are more protected over the next 45 to 90 days compared to just the vaccine booster therapy?
Is that for me?
Please, yeah, Phil.
Yeah. So there is a hangover effect. If you get acutely unwell and you go to hospital and you get sotrovimab, which is the monoclonal antibody, you will have protection beyond that acute event. Yes.
Okay.
I don't know off the top of my head, and I don't know even know if the company knows how long that lasts for, but it wanes just like you would if you're injecting a biologic. So
for a while, but an unknown period. Okay.
And maybe 3 months or something.
Okay.
Something like that.
We had another question that was sent in previously. I just wanted to hop back to that again because Phil, you and I spoke about it briefly. But if you could take that, EVU Shield or Shield available as a fourth vaccine. Would you like to comment on that? That wasn't on your list.
So EVU Shield is two separate monoclonal antibodies that are directed against the virus. Now, there are two types of monoclonal antibodies that are available for the virus. One that you get if you get infected, and that's called sotrovimab, and one that you can get prophylactically, and that's two monoclonal antibodies, and it's called EVU Shield together. Now, that's not a vaccination. It's monoclonal antibody against the virus, and people who are high risk are potentially eligible for that. Now, here in Queensland, we're currently just sorting out exactly who will be eligible. And because of the limited supply, we're going to have a sort of a tiered approach to it. Those people who are the very highest risk will get it first, and it will tier out depending on how much we get. And that's the fairest and the safest thing to do. And so if you think that you're a high risk, or your rheumatologist has said that you're a high risk, then again, like we've been talking about, you go and ask the question to your doctor, is this something that I should be receiving, or is this something that will be a good idea when I'm eligible for it?
Thank you. Now, again, Phil, there's quite a specific question from someone who missed the start of the session. I suspect it may well be the answer. Go to speak to your doctor, but I'll read it out anyway. I missed the start of the session. Is 20 milligrams of methotrexate per week high risk?
Well, there's two different things there. So one is, does 20 milligrams of methotrexate impair my response to vaccine? And probably a little, but 20 milligrams of methotrexate high risk for being unwell from COVID. So your risk of becoming unwell from COVID is much more strongly impacted by who you are and your other problems that you have, health problems. But again, you need to talk to your doctor, because there are so many different variables that influence your risk, including the disease you have, the medications you're on, who you are as a person, and those sort of things. And as Jane rightly pointed out, this is an individual conversation that you need to have with your doctor. And you can't be taking broad advice that we apply to a population and applying it to yourself. And so you need to ask the question.
Okay, thank you. Now, thank you everyone for the questions we've had so far. We're on still for a little while, so please feel free to ask some more questions with our distinguished experts here. It's a good chance to hear straight from the people who know, and thank you very much for Jane for really strongly emphasising, quite rightly, about the difference between the generic health advice that you get and you hear from ATAGI, you may read in the newspapers or wherever it's from, and the very specific individual advice that you may receive that relates to you, and perhaps moderating those two to make the best decisions. Now, I'll go back, Phil, if I may, to a question we had a little bit earlier. And again, it may be hard to answer this very specifically, but from a consumer who writes, I had Pfizer as my 2 primary and then a half dose of Moderna as a booster. Should I get another half dose of Moderna?
So that all depends if you're eligible for the booster dose. So you sounds like this person has had a normal vaccination series, and if they think that they might be eligible for a third primary, and their doctor agrees, then they can turn that booster dose probably into a third primary by giving another half dose. But again, this is something you need to talk to your doctor about, because it's influenced by lots of things: medication, disease, other things.
Thank you. Now, can I just pivot to a more general question? You touched on this in your slides, but I wonder if you could perhaps just expand on it, about someone with arthritis stopping their medication to allow the vaccine to develop full immunity, and whether that's ever recommended. I appreciate it may be an individual thing, but perhaps could you speak a bit more generically about that?
Yeah, so there's been some studies in influenza prior to the pandemic, and then there have been one study in a killed virus vaccine that has been published that I'm aware of, that shows that if you stop your medication after you get your vaccination, not before, you can boost the response. So that is your numerical level of antibodies that you have in your blood after the vaccination. Now, for those people who are, for example, John, 25-year-old, has rheumatoid, is well and stable on his methotrexate, that might be a really good option for him, because if he's going to flare, he'll get a minor flare. He understands the risk, and he's willing to take that risk to get a better vaccine response. So in that situation, in consultation with his doctor, John might decide to withhold his medication to get a better response. Now, there's another situation in that people have disease that can potentially impact irreversibly on organs, and they might be active, their disease might be very active, and stopping or changing their medications might have really serious consequences for them. So in those situations, again, in consultation with their doctor, they might say, I've heard about stopping medications, should I do that? And in that situation, the doctor may say, look, I don't think that's a good idea. Now, that doesn't mean that that patient is necessarily disadvantaged, because that's the whole point of the third primary vaccination, to try and give those people who might be vaccinated on medication this equivalent vaccine response or antibody response that a normal person would have on 2 doses. But again, I'd stress again that this is a very individual decision about whether to stop medications. Well, often people are on more than one medication. Some medications, you have to stop them for 3 months to make any difference to what the effect they have on your body, or you need to stop them for a year, for example. So some medications, it's just so individual, and it impacts on the disease as well, the patient's disease. So it's important that if you think that might be right for you, and that's something you should talk to your doctor about, whether that's the right thing to do.
Great, thank you. Jane, can I bring you in for a slightly different question about long COVID, and perhaps particularly as it may affect children, an increased likelihood of immunosuppressed people getting long COVID? Have you seen that in children? Is that something that you're looking at?
We are looking at it at the Children's Hospital, and there's a follow-up clinic. We haven't seen it as yet in our patient cohort, in saying that there's now just been a lot of infection around Victoria. So I'm from Victoria, and we've had, with schools going back, a lot of infections. So internationally, there's quite a lot of studies now going on that we're following really, really closely. The rates in children and teenagers, and particularly children and then teenagers, goes up, but it's nowhere near, fortunately, what's recorded in adults, in saying that there were a lot of issues around the types of studies that were being designed initially, and how they were kind of classifying the symptoms and what long COVID looked like. It does look like children seem to have less symptoms of long COVID and way less numbers of children have that compared to adults. But really, if you have a large number of young people with COVID infection, would be concerned about keeping a very close eye on that, and particularly for young people that have immunosuppression, making sure that there's not an increased rate. That hasn't been noticed internationally. We've certainly seen after viruses in teenagers, all sorts of other viruses that post-viral type syndromes like long COVID equivalents have been something that adolescents have had significant problems with over time. And I guess my hope as a rheumatologist, and I'm sure Philip has a lot of adult patients that fit in this category too. I sort of hope when I look at the COVID vaccine that came around, with just not fast, it came around fast speed-wise, but it came around because there was 30 years of incredible research, and then the entirety of the world's gaze and every single research lab, not every research lab, but just a vast amount of money and a vast amount of, every country that was working on that in huge collaboration. It was the most incredible scientific effort, and there'll be many people writing about how that came about so quickly. The sort of same thing with long COVID. So it's a long answer to you, is saying, I hope we're going to get very high quality research coming out about this, which will benefit patients at the coalface. There's been a lot of young people and adults who've had post-viral, well-defined and very poorly defined syndromes with a lot of, impact on them, with pain and a whole lot of other, very sort of chronic fatigue type illnesses. And I'm hoping the type of things that we're seeing in adults that are reported with long COVID, if we get really great research, will benefit a range of other conditions that rheumatologists are often involved with as well, and certainly paediatric rheumatologists see. So it's a long way of saying I'm hoping. We're not seeing it, but we're watching it closely.
But yeah, and can I just expand on that with Phil? Actually, and we're reading sort of 6 months into the pandemic, and people were recovering, obviously, and before the vaccines were coming, and then a lot of people were talking about long COVID and they weren't recovering. That doesn't seem to be much in the news now. It's not something people are talking about in the way they were before, and I didn't know if that's because many more people obviously now have vaccinations, so they're not having it as severely in the first place. If you haven't had it so severely, are your chances of long COVID reduced? Is that another reason to make sure you're fully vaccinated?
Yeah, so there is, if you're less likely to get long COVID if you're vaccinated, well, if your severity of illness is reduced. But I would echo what Jane said, is that we don't actually know what long COVID is. People feel unwell after becoming sick. There are many reasons. People can have physical injuries to their lungs, like lung inflammation, and they can feel short of breath, and that can be a reason for fatigue. And people can have normal lungs and feel fatigued. And so I think it's a condition that we're going to have to think about a lot, because it's going to be I think it's the label for lots of things. People feeling unwell after their virus, and we're going to have to try and tease that apart. And it's not exciting because it's long, tedious work in the lab and examining people, and I hope that governments allocate good amounts of money to trying to sort this out, because COVID's with us for now.
And as Jane pointed out, there are many other diseases, viral diseases, that can have long effects.
I'm going to go further than that. I'm going to say it has to be funded, because around the world there is, if you're on Twitter at all, you will see the incredible patient advocacy around how incredibly crap people that have long COVID is. And even if it's 1%, and I suspect it's a bucket load more than that in adults, there is a significant post-viral syndrome of whatever. They're actually not calling it long COVID now. There's a whole lot of advocacy from clinicians as well as patients to call it a range of other things, and they're discussing that now, as clinicians always do on different continents. They argue it, which must annoy patients a lot, I'm sure, and people with the condition just get on and find some better treatments. But I think the problem with this, and I think that we need to be very, very aware of this as medicine and doctors, and we know healthcare system is massively siloed a lot of the time. If you have something that people don't understand and you feel like crap, you fall through the silos and you bounce between all the different ologists. And my hope, and I hope I'm right, is that because this has been a global pandemic, it has affected every single person in the world. It will shine a light on this, and we will be able to hopefully turn our gaze and work collaboratively. There are many conditions, and I have to say often that females have had, that medicine has been quite sexist, it's often racist, and we don't do very well. And I think if we think about painful conditions, we often don't do very well at actually funding the research and actually doing really high quality research. Musculoskeletal medicine being one of the things that has not been sexy and not funded. So, long COVID, if you're fatigued and brain fog and can't function and you're not working, that has not been something anyone has been particularly interested in funding in the past. It just has not. But it is, if people had chronic fatigue, there's been a lot of eye rolling, and we know that that is a real condition. But there are a lot of clinicians, because they didn't know what to do and we didn't have treatments, that were unable to actually tackle that in any way. And I think that I'm hoping there will be, because of the universal experience of whatever long COVID ends up being, we will get a way of addressing it, a better language and better treatments.
Thank you. Well, I can certainly reassure all those that are watching that Arthritis Australia, as a consumer advocacy organisation, is banging that drum very, very loudly with the government. In fact, we've been talking to the major parties about the budget statement and looking at our election asks, and that sort of increased research, really a big step change in that kind of research. As you say, that may drive it as well. And I guess, if there's a very large number of people, and 1% is still a very large number of people, that's going to drive economic activity, which will be another incentive for government to put some investment into this. So thank you. That's it's kind of positive news that may well come out of this, if it makes people realise. Can I go on to another question about flu shots soon being available? How long should you wait after your booster before having a flu shot? Phil, could you take that?
Yeah, I sound like a broken record, don't I? Look, this really depends on what's happening, because, for example, if you're going to withhold medication, you don't want to put long gaps between your vaccinations, whereas if you're not, then maybe you can put bigger gaps. I think the pretty default advice might be 7 days. Maybe I'm wrong, Jane, but look, I would just talk to the person who you're giving your vaccine, and if you're thinking about withholding medications, then you need to discuss that with them.
Okay. Now, here's a slightly different question, again, Phil, from someone who says, I'm on Actemra, which is what they're using to treat COVID with. What does that mean for me? Am I less likely to get COVID? Is there a relation between the two?
So the answer is no. So Actemra is used to treat people who become severely unwell with COVID with a significant inflammatory response. So one of the things that makes people unwell is the body's own immune system when it reacts to the virus. And tocilizumab, Actemra, is used in that context. It doesn't stop you getting the virus. So you should just behave in a way that that's consistent with that, and still get your vaccinations and follow public health advice.
Okay, thank you. Can I just a bit of feedback for Jane there? Someone who's written in bounced between ologists, applause. So you've certainly
for lack of applause for bouncing between ologists, but applause that happens often. We all know that happens.
For noting that.
Can I say that we're talking about flurona? So what we do not want is people to be having flu and corona. So that's what we're talking about this winter, because we've had 2 years, particularly places like Victoria, but 2 years around Australia where we've been changed our behaviours, we've stayed away from people. So we're bracing and expecting a massive flu season this winter. That's kind of the prediction. So get your flu vaccine, work out when you can get it early. So just time that with your doctor. But just knowing that if that happened and there was a new variant or a big upswing in the BA2 in your particular region, you just want to avoid that perfect storm for you.
Because lots of people have been worrying about things other than flu, and they haven't necessarily got their flu vaccinations along this time. But yeah, definitely.
Okay. And your advice generally from both of you about the flu vaccinations, is it the same strength of advice about getting the COVID vaccination?
Absolutely. Yeah. Jane rightly made the point, if people are sitting there worrying about having a virus that can kill you, I think we should worry about having two viruses at the same time that can kill you, because one thing that doesn't really get in the press much is that people die every year of the flu virus. And those are people who are often more unwell or other infirm. And so if you've got COVID and you get the flu, you're really giving yourself a pretty bad you're putting yourself in a bad situation. And we have the ability to try and reduce the impact of that with the vaccine. So it's definitely, I would certainly strongly recommend it.
Thank you. Now, I'm conscious we've only got a couple of minutes left, and I've got a couple of questions I'd like to get to, so we can have perhaps some brief answers. Someone has written in about once you've had the COVID regime of vaccinations, do you get any sense that ATAGI is currently predicting ongoing vaccinations 6 monthly or annually? Do you think it's going in that direction?
Jane probably knows more about this than me.
They are watching it very, very closely. The one advantage of other countries being a bit ahead of us in their schedule and in their waves is that we've always got that little bit of information. So there is the potential for that. Everyone would prefer not to have to do that, absolutely. But that is something that the idea of a booster, like we do with a flu, where there's a shift or there's a variant shift or there's a change, that might be something we might need. It may just be, it ends up being for people that are at higher risk. And given I'm talking at the Rheumatology Forum for immunosuppressed patients, potentially that might be the group, or it might be elderly people. So it'll be very much data driven. It'll be about who is at risk and where are they at risk. So if they're, that'll be what will drive that.
Phil, a very quick question, maybe a yes or no. I'm on 1,440 milligrams of, I'll probably pronounce this wrong, sorry, mycophenolate acid, 4 tablets a day. Am I considered highly immunocompromised?
So you are eligible for the third primary vaccine under the ATAGI guidelines. Okay. So yes, that's something that we recommend.
Great. Slightly longer question, but we'll try and get through it quickly. My rheumatologist confirmed after 3 vaccinations, I have no COVID antibodies. I have 2 Pfizer doses, 1 full Moderna as my 3rd vaccination. What's the recommendation for the type of vaccination to have a booster to try and get some immunity? Currently taking Avara, rituximab and methotrexate.
So this is a slightly special situation. So rituximab impacts significantly on the ability to form antibodies. And so this is those on rituximab, some of the people near the front of the line for getting this prophylactic monoclonal antibody called Evusheld. So people who are on rituximab, especially those who know that they don't have vaccine response and it's being tested, those are the people who, it's probably a good idea to talk to your doctor about whether they want to put their hand up for Evusheld when they're eligible.
Great, thank you. Now, we are at 7:30. I just want to make one other point. Someone raised in with a question about why we're doing this now, because ATAGI have been updating the guidelines and the process of communication of patients with rheumatic conditions. And I can tell you from my colleagues at the Australian Rheumatology Association that there is plenty of general vaccine information for rheumatology patients available on the ARA website, which is rheumatology.org.au. And if you look in there for patients' medication information of vaccination, and similarly on the Arthritis Australia website, there's lots of information. It's been there for quite some time. But as both Philip and Jane have said, really, really important in individual circumstances to speak to your GP and speak to your rheumatologist. So maybe inform yourself about those, and we will try to keep those updated. We've had some medicine shortages recently, many will know, and we and the Australian Rheumatology Association have been working together to make sure we're giving the most up-to-date information, but it's often constantly evolving, and we want to make sure it's kept up to date all the time. So at that point, can I say thank you very much on our behalf, all of us, to Philip Robinson and Jane Munro for giving up your time this evening to give us really great answers. Thank you to all the people who've dialed in, who are watching. I hope you're better informed. I certainly am. And thank you very much to all those who have given us questions and made this such an interactive session. Could I thank, on behalf of Arthritis Australia, to colleagues at the Australian Rheumatology Association who've kindly hosted this on their platform, and to my colleagues in those organisations, Tracy Rudd and Lindsay Parks, who kindly been working behind the scenes to do all the technical stuff to make this possible, without which it couldn't happen. So thank you very much. I will remind everyone that this session has been recorded. We will put it up on the Arthritis Australia website if you'd like to listen. And if you know people who also would, pass the word around that anyone can listen in and hopefully be better informed. So thank you very much again to our speakers. Thank you to all of you who are have listened in and have asked questions. Thank you and good night. Thank you.